biopsy channel of the endoscope, and it is CO2 is delivered through a cartouche under high pressure, and that's how the powder is sprayed. So Hemospray is an inert mineral powder delivered by the aerosol delivery system, and it works by coating the bleeding site and absorbs the water from the blood, which leads to a concentration of platelets and clotting factors, so speeds up coagulation. But then it also has a tamponade effect on the bleeding vessel as it forms a mechanical barrier. So we're excited about this novel agent because there are preliminary data suggest that it augments hemostatic efficiency. It's becoming increasingly available and is licensed for endoscopic treatment of non-varicose bleeding within Europe. Its history lies within associated substances used on battlefields for hemostasis. As I said, it's an inert substance and it passes through the lower GI tract within 72 hours. So there's no systemic absorption, so it's felt to be quite safe. So this is just a picture of the Hemospray in use. As you can see, the catheter passes from the tip of the biopsy channel and then it deploys. As it falls in the fashion of snow and coats the bleeding site. So it can be used as monotherapy for primary control of bleeding or perhaps when your other modalities have failed. So we wanted to explore this further. The largest study thus far is a European multi-centre survey where it was used as monotherapy for primary hemostasis. And hemostasis was achieved in 85% of their cohort of 66 patients. There are also anecdotal case reports and case series for varicose bleeding, but not in large numbers. So this is our hospital, Barnet Hospital in North London. It's a district general hospital associated with the Royal Free London NHS Trust. It has 450 inpatient beds. We have a 24-hour accident emergency. In terms of endoscopy services, we have daily medical gastroenterologist delivering lists in hours, meaning between 9 to 5. Out of hours, we have a GI bleed rota, which is an on-call service where the consultants will come in from home to perform the endoscopy in the emergency theatres with the help of non-endoscopically trained theatre staff. So we conducted a retrospective analysis of all patients treated with Hemospray between September 2013 and April 2015, a 20-month period, and reviewed their case notes. We're quite fortunate that we have electronic records. A total of 58 patients were treated during this time period, mean age about 65 years, 42 males, 16 females. The average pre-endoscopy Rockall score was 3, post-endoscopy 5. The Blatchford score for risk assessment on admission, the average was 9. In terms of why the endoscopies were undertaken, overwhelmingly 50% had some overt bleeding with melena. A further 27% had profound anemia, and other indications including hematemesis, known varices with anemia, and there were a couple of cases of dysphagia and dyspepsia. So how are we using Hemospray in Barnet? Well, it's been used as monotherapy in approximately a third of patients. Just over half of the patients, it was used as adjunctive therapy, meaning where the conventional dual modality therapy had failed to achieve immediate hemostasis. It was also used as rescue therapy in 20%. So this demonstrates the type of lesions that were encountered, and as we can see, peptic ulcers were the most commonly treated, and the split between monotherapy, adjunctive and rescue therapy is fairly even. But what we were interested to see was that it was used in monotherapy in all tumour-associated bleeding. And we thought that this was because with tumour-associated bleeding, it's quite diffuse and non-specific, and the benefit of Hemospray is that it's non-contact and atraumatic to the area. Also, with varices, we found that it's used as an adjunctive modality to band ligation in the majority of patients with variceal bleeding. It was used in monotherapy in a few cases, perhaps because this was felt that the varices weren't large enough a target to band. Other lesions included polyps, portal hypertensive gastropathy, and there was a case of a Mallory-Weiss tear also. So our results are good in terms of the rate of hemostasis achieved. There was only one patient where it was unsuccessful. This was a dualifoid lesion, and Hemospray therapy was applied as solitary endoscopic therapy, as it was in a difficult location on the posterior duodenal wall. This patient was elderly and on aspirin. They ended up having a repeat endoscopy with conventional dual therapy. Of further interest was the fact that Hemospray monotherapy was helpful in 2 patient cases who had already had arterial embolization for an oozing visible vessel at index endoscopy. So these patients, they obviously were inpatients. They had their second endoscopy with Hemospray monotherapy, and this bided them some time whilst they waited transfer to the Royal Free, which is our tertiary centre. In all of the cases, there were no procedural complications reported either during the delivery of the therapy or immediately post-application. There were no treatment-related adverse events, and there was one inpatient death within our cohort, which wasn't attributable to the bleed nor the endoscopy. So data raises the points that Hemospray is an easy-to-use topical therapy which has simple handling. It's useful for a wide range of causes, and the vast majority achieve hemostasis. It's particularly useful for those lesions that are in difficult locations, as the en face approach is not required, and you don't require the accuracy of more skilled endoscopists. It also has a very favourable safety profile. So also our data demonstrates that it could be particularly helpful as first-line therapy for diffuse oozing bleeding associated with tumours, and perhaps this could even be extrapolated to portal hypertensive gastropathy. It's useful as an adjunctive therapy in ulcer-associated bleeding, and perhaps could even be a useful bridging monotherapy in variceal bleeding, particularly out of hours when you don't have the skilled endoscopy staff with you. So in conclusion, we suggest that Hemospray should be considered as first-line intervention for tumour-associated upper GI bleeding. We should also consider Hemospray to be incorporated into the national guidelines for both non-variceal and variceal hemorrhage. But obviously, larger controlled studies require, as the data is currently lacking. And that's the end of my talk. Thank you.
Thank you very much for this nice trial, for sharing it with us. Are there any questions from the audience?
Were any of your 58 patients anticoagulated with an INR greater than 1.5?
So there were about 4 that were anticoagulated. So their INR was corrected prior to the endoscopy.
Okay, thank you.
Congratulations for your talk. There is an interesting study, and is a large number of cases regarding the studies with Hemospray in the literature. We know as endoscopists that there is a magnific tool and we want it, but we know also there is a high cost of the procedure. My question is, do you have a specific guideline or indication when you are going with Hemospray or with the other techniques?
So I think we're still obliged to follow the national guidance for non-variceal hemorrhage and also for variceal hemorrhage. The NICE guidance still states that we should use conventional therapy for non-variceal hemorrhage, such as adrenaline and clips. But obviously, guidance can only be taken into account in the clinical context. So I think at the moment, endoscopists are using Hemospray certainly within our hospitals, within our own trust, at their own discretion. And certainly it seems to be used for monotherapy where there isn't a discrete bleeding point, or the bleeding point isn't quite easily visible or accessible for clipping or injection.
When do you think it is good to have the second look endoscopy after Hemospray appliance?
Yes, I think there is one study that's already looked at that, and they had very good results where there was no active bleeding on the re-look endoscopy within 24 hours, and also the Hemospray had moved from the lesion.
So you usually make a second look after 24 hours, or
so it's dependent on the local services. Unfortunately, ideally, yes, we want a study which looked into that, but actually, as I imagine across other centres within Europe and beyond, we aren't able to provide that service.
Okay, and my last question, we know that there is not an usual indication for the variceal bleeding, and there are some data in the literature that report some secondary effects after application of Hemospray. Did you have something like this in your patients?
No, we didn't have any adverse effects. Certainly those that underwent a repeat endoscopy, and our guidelines are that all patients with varices who are treated endoscopically then should have a re-look endoscopy minimum within 2 weeks if they remain stable until then, and are entered into part of the variceal screening branding program with re-look endoscopies every fortnight or every 4 weeks. And certainly there were no associated reported side effects from the Hemospray at those re-look endoscopies.
Okay, thank you.
Chemotherapy, it is at the start of treatment, but not treatment. I agree with Professor. So I know that your experience is not much large. So that chemotherapy can be to stop bleeding only, not to treat. After that, you look for treatment.
Yes, they all require definitive.
I know that your experience large, but not large enough.